Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, will be presenting an article published in the February 2025 issue of the Indian Journal of Anaesthesia. It is titled Internal Jugular Distensibility Index as a Predictor of Fluid Responsiveness in Adult Patients Undergoing Elective Surgery, a Prospective Accuracy Study. Fluid administration decisions during surgery are challenging, with nearly 50% of the unstable patients not responding adequately. Both excessive and restrictive fluid management increases the risk of acute renal injury and postoperative mortality. The IJV Distensibility Index is a potential non-invasive tool for assessing fluid responsiveness, offering an alternative to echocardiography. The studies show that IJV Distensibility Index has a high sensitivity and specificity in predicting fluid responsiveness in septic and post-cardiac surgery patients. So this study aims to compare this IJV-DI with transthoracic echocardiography for fluid assessment in elective surgeries. The primary objective was to assess the suitability for measuring fluid responsiveness by using IJV Distensibility Index measurement method compared to the transthoracic echocardiography. The secondary objective was to find out the sensitivity, specificity, positive predictive value, negative predictive value of the best cutoff for determining fluid responsiveness using both methods. So institutional ethical committee approval was taken and the trial was registered. The study was a prospective observational study that included patients from ASA grade 1 to 3, 18 to 65 years of age with BMI less than 30 kg per meter square. The patients excluded were those with fluid overload, AKI or CKD, cardiac disorders, raised intra-abdominal pressures, anatomical anomalies in the neck and chest, jugular venous thrombosis, SVC syndrome, and prior jugular vein catheterization. Written informed consent was obtained and the patients were induced with propofol, fentanyl or remifentanil followed by atracurium or rocuronium. And tidal volume of 8 ml per kg, predicted body weight with FiO2 of 0.5 and a PEEP of 5 centimeters of water was given. The transthoracic echocardiography was done by a trained anesthesiologist. To assess the right IJV's diameter, the patient was laid on their back at 30-degree angle and rotated to the left side by 30 degree. And the IJV was visualized using a high-frequency linear transducer in short axis at the level of the cricoid cartilage. It was recorded over 3 respiratory cycles using M-mode scanning. For IJV Distensibility Index, D max was calculated at the end of inspiration, which was the maximum diameter of the IJV, and DI was the minimum diameter of the IJV at the end of expiration. The distensibility index was D max minus D min divided by D min into 100%. For TTE based views, the parasternal long axis view was taken to measure the LVOT diameter at the base of the aortic valve, and the cross-sectional area was calculated using pi d by 2 square formula. In the apical 5-chamber view, the LVOT VTI was found and the stroke volume was calculated, multiplying the cross-sectional area with the velocity time integral obtained from the apical 5-chamber view. After the initial measurement, 250 ml of crystallite bolus was given and post-intervention hemodynamic measurements were done. The difference in stroke volume del SB and del IJV distensibility index was calculated before and after the fluid bolus. And the subjects were divided either into non-responder and responder. More than 10% increase in the difference of stroke volume before and after the fluid bolus was taken as a positive response. And all those measurements were done before the surgery began. So the primary outcome was the assessment of suitability of measuring fluid responsiveness by using the IJV distensibility index versus the echocardiography. The secondary outcomes was to find out the sensitivity, specificity, positive predictive value, and the negative predictive value using both the methods. Sample size was based on a previous study, which came out to be 72 samples with a 10% dropout rate. So this is the flow diagram where we can see that after the patients were included in the study, they were induced, mechanical ventilation was started, and the measurements were done. After which a fluid challenge of 250 ml over 10 minutes was given, and again the measurements were done, and the patients were either divided into responders or non-responders. So this is the table showing the baseline characteristics. So according to the primary outcome, the difference in the Dell IJV distensibility index was significant in between responders and the non-responders. Similarly, the systolic BP, heart rate, and the stroke volume difference, all these were significant between the responders and the non-responders. Again, in this ROC curve, we can see that the cutoff value for distensibility index is 12.62% with a sensitivity of 84.4% and a specificity of 79.4%, which is at the intersection point, also known as the Uden index. Coming to the positive predictive value of which is found to be 0.84 and a negative predictive value of 0.79. So from this study, IJV distensibility index is a reliable, simple and alternative tool for predicting fluid responsiveness. Most study participants were fluid responders consistent with previous research. IJV-DI measurement closely matched the TEE measurements with an agreement of 87.1%. Different studies have reported varying IJV-DI cutoffs influenced by the response criteria and patient conditions. IJV-DI shows a moderate positive correlation with stroke volume after fluid administration. Study limitations include a small sample size and exclusion of patients with cardiovascular dysfunction requiring further research. So to conclude, IJV distensibility index is a reliable tool for diagnosing fluid responsiveness. It can help reduce unnecessary fluid administration in non-responders, and larger studies are needed to improve its reliability, and future research should focus on fluid restricted patients. Thank you.